Hello everyone. Today I am going to discuss about role of transesophageal echocardiography in non-cardiac organ transplant surgery. I am Dr. Jigisha Pujara. I am working as a professor in Department of Cardiac Anesthesia at UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Transesophageal echocardiography is a minimally invasive monitoring tool that can provide real-time visual information on ventricular function and the hemodynamic volume status in patients undergoing organ transplantation. Two-dimensional and the Doppler imaging TEE complements other monitoring modalities like invasive arterial monitoring and flow-directed pulmonary artery catheterization and provide the information which are not obtained by the other means. Patients undergoing major organ transplantation, heart, lung and liver have undergoing cardiopulmonary dysfunction that is severely challenged during and is amenable to evaluate by the intraoperative TEE. Here we focus on transesophageal echocardiography during liver and the lung transplantation. Role of TEE in orthotopic liver transplantation. Routine use of the TEE 40 to 72% in the high volume liver transplant centers only. Still we are lacking in 100% of the implementation of TEE compulsory in this scenario. American Association for the Study of Liver Disease AASLD states that TEE should be used in all liver transplant candidates to assess the chamber size, hypertrophy, systolic and diastolic function, valvular function and left ventricular outflow tract obstruction. TEE is a tool as a cardiovascular monitoring, evaluate lungs and pleural spaces, assess the hepatic vein blood flow and inferior vena cava anastomosis and the patency. Indications of the TEE are monitoring cardiac function, intravascular volume status, assess the inferior vena cava patency once there is a stricture of the suprahepatic inferior vena cava anastomosis suspected, hepatic vein and IVC thrombus which can lead to the allograft congestion and hemodynamic instability. Basic intraoperative TEE during the OLT. Real-time information on the left ventricular size and function, valvular anatomy and function, volume status, pericardial abnormalities. These are the basic things we should see in all the patients apart from the problems happen during or the post liver transplantation. TEE for the diagnosis and assess for the intracardiac thrombus, left ventricular outflow tract obstruction, right heart function, pulmonary embolus, pulmonary hypertension, cardiac stents, pericardial and cardiac tamponade, aortic atheroma and acute aortic syndrome. There are basic TEE examination include the 11 primary views for the transesophageal echocardiography intraoperatively. Mid-esophageal 4-chamber view we have obtained at around in adult cases around 30 degree at 0 degree multiplane angle, and mid-esophageal 2-chamber view we obtained around the 90 degree omniplane. Mid-esophageal long axis view we can obtain at around 120 degree omniplane angle from the mid-esophageal 4-chamber view, and mid-esophageal ascending aortic and the arch long axis view we can withdraw the prop from the mid-esophageal 4-chamber to the 5-chamber ascending aorta, then turn the transesophageal echocardiography prop towards the left and we can get the arch long axis view. If we change the multiplane angle to the 90 degree we will get the short axis of the arch. Mid-esophageal ascending aorta short axis view and mid-esophageal aortic wall short axis view around 45 degree we can get this view. Mid-esophageal RV inflow outflow view from the 4-chamber view when we change the multiplane angle to the around 60 to 70 degree we can get the tricuspid wall and the pulmonary wall, and that is the inflow outflow view. In mid-esophageal bicaval view we can get it this view with the around the 90 to 100 degree angle. There are transgastric views we can have. These views are transgastric mid short axis view, descending aortic short axis view and the descending aortic long axis view. These views help, we'll see later on which are the places where these views are useful. Comprehensive advanced T includes 17 views which help in the diagnosis and ability to guide the perioperative decision making. Apart from the 28 basic views, there are few modified views which help in the diagnosis of the problems during the intra and the post-operative period. TE used to evaluate other organs including the liver, lungs, spleen and kidneys. Some non-traditional TE imaging can be used to diagnose intraoperative non-cardiac pathology which lead to the definitive surgical care. We'll go with this case scenario. One case, 29-year male patient with the end-stage liver disease with the portal hypertension, hepatic encephalopathy, jaundice and the pruritus and the holosystolic cardiac murmur. Patient received the post-cross clamp offer after that from the 21-year-old brain dead donor with a 40 to 50% the fat. Intraoperative monitoring, arterial line CVP and the transesophageal echocardiography. Operation was performed with cable replacement, portal vein to portal vein and the recipient hepatic artery to the reconstructed donor hepatic artery. Prior to the reperfusion, patient was on 0.04 microgram per kg per minute of the epinephrine and required 3 units of the PCV. At reperfusion, multiple boluses of the vasopressin and the epinephrine and multiple fluid boluses required. At this time, allograft appears congested and enlarged. T probe was inserted, thrombus was noted in the hepatic vein, then in the IVC also. Modified transgastric hepatic vein view by rotating the probe clockwise from the transgastric view, omniplane angle 60 degree to find the long axis view of the hepatic vein. This picture showing left side echo image showing longitudinal liver with the IVC and hepatic vein showing the thrombus. Here you can organize thrombus you can see. On the right side of the screen showing the longitudinal image showing IVC and middle hepatic vein thrombus, grayscale artifact over the right atrium from the simultaneous use of the T we can see. Alternating between modified transgastric hepatic vein view and modified bicaval view, IVC from the hepatic vein to the atriocaval junction can be visualized, which confirm presence of the IVC, suprahepatic anastomotic stenosis and the hepatic vein thrombus, resulting in the hepatic outflow obstruction, allograft congestion and the hemodynamic instability. Surgical intervention, IVC thrombectomy and revision of the suprahepatic caval anastomosis resulted in the subsequent allograft decompression and patient recovered completely from the liver transplant. Here in the figure, left side showing the echo image, transverse hepatic vein showing minimal patency of the right hepatic vein. You can see on the image, and on the right side of the screen there is a transverse hepatic vein showing partial patency of the left hepatic vein only. Color Doppler artifact from the simultaneous use of the T can be seen. Here again echo image showing left upper suprahepatic IVC stenosis near the right atrium with the turbulent flow. You can very well see the turbulent flow. On right side upper hepatic vein stenosis, modified hepatic vein view. You can very well see the narrowed hepatic vein on the right side upper image. On left side lower image, you can see the IVC stenosis and turbulent jet. There is play of the color seen and turbulent jet is seen here. On the right side lower image showing the thrombus at the RA IVC junction. Lower esophageal hepatic view. There are few views useful during this liver transplant surgery. Our primary diagnostic use is inferior vena cava collapsibility and the diameter, hepatic venous flow velocity, hepatic image setting angle at around the 20 degree and probe adjustment rightward. Transgastric modified hepatic vein view 0 to 20 degree. At the level of the lower esophageal, and maneuver will be like from the prior image, continuous wave Doppler, advanced monitoring is done. And clinical utility, inferior vena cava, hepatic veins, inferior vena cava diameter for right atrium size, etc. can be measured during in these views. Right side of the see the echo images, 2D figure showing this IVC and the hepatic vein, and 3D image of reconstructed from the 2D on the right side, and there is 2D image on the left lower down, and there is a 3D reconstruction on the right. Another case, accidental laceration of the IVC during left lobe liver resection surgery in 67-year-old female with the giant hepatic angioma, which required the complete clamping and the re-establish the blood flow using the Edward bovine pericardial patch. After declamping T to check the patency of the IVC and blood flow in suprahepatic veins, multiplan T is able to identify three main hepatic veins, right, middle and the left. Here you can see the IVC end-to-end infrahepatic rescue cavostomy, and on the right side of the showing the echo image of the same. Usually the normal hepatic waveform has four components: A retrograde A wave, right atrial contraction, an antegrade S wave that is due to the right ventricular systole, a transitional V wave, pulmonary vein closure, and an antegrade D wave that is due to the right ventricular diastole. Flow above the baseline indicate flow towards the transducer, and flow below the baseline indicate the flow away from the transducer. Here you can see the echo image of the pulmonary vein pulse wave Doppler and normal triphasic hepatic Doppler waveform. The four waveforms contributing the normal spectral Doppler waveform are indicated as the A wave lies below the baseline, and that is retrograde component, and the S and the D wave peak above the baseline and are caused by the antegrade blood flow towards the right heart, and the V wave, a transitional wave, may peak just below or above the baseline. One is we can see we have to ask ourselves whether there is a flow in the pulmonary vein or not, and another question we have to ask is whether it is directed towards forward or the backward, and what is magnitude relationship between the ST. Normal S systolic component is more than the diastolic component if there is a normal or there is a reversal of it, and what is the magnitude of the A wave. Another case, during the OLTX, most dangerous phase is the reperfusion phase, in which surgical clamp is removed, leading to the sudden release of the cold, acidotic, oxidizing and the hyperkalamic fluid into the circulation and lead to the reperfusion syndrome in the 42% of the cases, and manifest as a temporary myocardial dysfunction with reduction in the heart rate, increase in the pulmonary artery pressure, reduce cardiac venous return that is preload, and decrease in the mean arterial pressure that is afterload in the 30% of the cases. Here patient can have low preload and the afterload, and patient can have profound cardiovascular collapse. If patient is having the LVH and long anterior mitral leaflet, that in such situation this acidotic reperfusion injury causes alveolar obstruction, and that management consisting of just giving the fluid, increasing the afterload with the vasoactive drugs, and reducing the cardiac frequency. So rate control, fluid therapy and the afterload increase with some vasopressors is required rather than doing the vasodilator. So the T will help in this scenario. Now coming to the role of T in the lung transplantation surgery. The indication of the T use in lung transplantation is only a class 2B recommendation by the American Society of Echocardiography, and the absence of guideline from the Society of Cardiovascular Anesthesiologists may explain its low rate of the adoption. Lung transplantation is the definitive treatment for the end-stage lung disease refractory to the guideline-directed medical therapy. It is a complex surgery involving vascular anastomosis of the donor and the recipient pulmonary arteries, and anastomosis of the donor pulmonary vein cuff to the recipient left atrium. The patency of this delicate vascular anastomosis during and after the lung transplantation are critical to the survival of the lung allograft and affect the patient morbidity and mortality. There is bronchial transplantation occur, but T will not help much on the bronchial transplantation. For that we require the fiber optic probe, and obstruction of the pulmonary artery anastomosis impedes blood flow into the lung allograft, which increases the right ventricular afterload. This can lead to the pulmonary hypertension, RV dysfunction, hypotension, hypoxemia, primary graft dysfunction, and eventually allograft failure and the death. Likewise, pulmonary vein cuff obstruction, which can develop as a result of allograft torsion, lung allograft recipient thorax size mismatch, and the anastomosis, stenosis, or the thrombosis, which also can lead to the similar manifestations. So, one by one we will see the case scenario regarding these also in next slides. In severe cases, both pulmonary artery and pulmonary vein cuff obstructions may necessitate the mechanical circulatory support. As a result, a high degree of the suspicion of and the timely diagnosis of these conditions in the intraoperative or the postoperative setting can prevent the hemodynamic decompensation, allograft failure, and the morbidity. Assessment of the RV. RV is a thin-walled crescent-shaped low-pressure high-volume pump assessed by geometry-dependent planimetry and the tricuspid annular plan systolic excursion, geometry-independent by Doppler echocardiography, and quantitative by the RV ejection fraction, and the qualitative by the septal curvature and real-time visual assessment methods. Planimetry of the RV is in the mid-esophageal 4-chamber view, RV inflow-outflow view, bicaval view, and the transgastric short axis and long axis view. At end diastole and end systole, intracavitary area traced manually or by the automatic body detection system, and RV fractional shortening can be calculated. TAPSE based on the concept that most RV ejection is caused by the contraction in the long axis. Careful image acquisition is required to visualize the RV free wall septal junction in both end diastole and the end systole. Maximum acceleration of the blood in the pulmonary artery can also be used as an index of the RV ejection. And of course, the global perfusion of the RV can be seen. In practical terms, RV function measured qualitatively, RV and systolic and end diastolic areas assessed visually, and ejection fraction estimated. Interventricular septum visually assessed for the paradoxic curvature. Normally, septum bulges into the left to right due to the higher left-sided intraventricular pressure, and in acute RV dysfunction, septum bulges from the right to left. Paradoxical septum shift occurs in late diastole with the RV volume overload, and in the end systole and early diastole with the RV pressure overload. So, we can make out is there any pressure overload or the volume overload. Immediate post-transplant PVR decreases can precipitate RV outflow obstruction in patients with the severe RV hypertrophy. Increase in the pulmonary vascular resistance, most common cause of the RV failure in post-lung transplant period. Tricuspid valve and the pulmonary valve. Antegrade ejection of the blood in the pulmonary artery depend on the competency of the tricuspid and the pulmonary valve. Severe TR result in the overestimation of the RV function and volume normal EF with the severe RV dysfunction. Severity of the tricuspid regurgitation based on the ratio of jet area to the right atrial area. Tricuspid regurgitation and pulmonary insufficiency are frequently result of pulmonary artery hypertension. Doppler echo of the TR jet used to estimate peak pulmonary artery systolic pressure, and during the pulmonary regurgitation, high velocity flow observed throughout the diastole in the RV outflow tract. Severity of the tricuspid regurgitation in grade 1, there is a jet area to the right atrial area ratio is less than 15. In grade 2, ratio is less than 30. In grade 3, ratio is less than 60. And in grade 4, ratio is more than 60. Here, a table showing the systemic approach in the perioperative assessment during the lung transplant surgery. we have to see the structure like interatrial septum. The pre-transplant, we have to see this for the pre-existing patent foramen oval or the atrial septal defect, and view used for this is the mid-esophageal picaval view. Right ventricle structure can be seen pre-transplant for the RV size, dilated RV, RV hypertrophy, RV function, and abnormalities intraoperatively. Important points are during the induction we have to see the RV, during the one lung ventilation, surgical manipulation, clamping of the PA, at the time of the reperfusion and at the time of the chest closure, and post transplantation RV function, preload, and of course the air if patient is on the bypass, and mid esophageal 4-chamber view, Stapse in the transgastric long axis view and the transgastric short axis view should be visualized. Pulmonary vein baseline diameter and the velocity we have to observe preoperatively. If any thrombus, kink, stenosis, size and velocity. Pulmonary hypertension can be seen post transplant. To visualize the pulmonary vein, we have to do the 4-chamber mid-esophageal 4-chamber view as well as the aortic arch short axis view. In both the views, we can see the pulmonary veins. When we rotate the prop towards the left, we can see the left upper and left lower pulmonary veins, and when we rotate the prop towards the right, we can see the right pulmonary veins, upper and middle. Tricuspid valve, pre-transplant we have to see for the TR severity and systolic PA pressures using the TR jet, and post transplantation we have to see the pulmonary hypertension, mid-esophageal 4-chamber RV inflow outflow view, modified bicaval view, and upper esophageal aortic arch short axis view are used for this visualization. And pulmonary artery, usually only the main pulmonary artery and the RP are visualized. Left only just in the beginning of the left pulmonary artery we can see in the TEE. Baseline diameter and the velocity we have to observe preoperatively, and postoperatively if there is any thrombus, kink, stenosis, size and the flow, air, etc. should be seen. In upper esophageal ascending aorta short axis view. Left ventricle we have to see for the left ventricular size and function preoperatively, and postoperatively of course we have to see the air, contractility, preload, etc. in the mid esophageal 4-chamber view and transgastric short axis view. Other things we can see is the ECMO line placement. We have to see if at all required post transplantation, and we have to see for the left ventricular condition with aortic dissection if on the CPB, and cardiac tamponade, hemothorax, etc. We have to see mid esophageal 4-chamber view. Postoperative hypoxia, obstruction to normal pulmonary blood flow and intracardiac shunt, ASD or the PFO are major anatomic causes for the hypoxia. T can visualize right pulmonary artery anastomosis 100% and left 71%. Color flow mapping at suture line can show areas of the turbulent flow. Pulse wave Doppler can be performed above and below suture line to the measure a gradient across the anastomosis. Pulmonary venous connections are visualized by the TE. Pulmonary vein diameter, color flow pattern and the pulmonary pulse wave Doppler profile can be very well visualized. Diameter of the pulmonary vein and mean pulmonary venous velocity are greater in allograft than in the native lung, because native lung may be slightly diseased and the allograft is now more functioning, so there is more flow in the transplanted lung. 2D and the color flow mapping may show the thrombus obstructing pulmonary venous blood flow from the allograft. Bicaval view helps to see the direction of the flow across the PFO or the ISD, and the contrast echo by the agitated saline is used to see the patent foramen oval. Coming to some case scenario, there is a patient posted for the bilateral lung transplant. After successful right allograft, patient developed severe PH and the RV dysfunction. Detected by the TEE, CPB was instituted and left lung implantation was completed. PAH and the RV dysfunction persisted after both the transplanted lung, and again T was done, which showed the right pulmonary artery anastomotic stricture. Right pulmonary artery anastomosis revised with the which corrected the pulmonary artery pressures, and the temporary VA ECMO established in that patient for 24 hours, which weaned off successfully and the RV function normalized. Here we can see the image. All images were obtained from the modified mid-esophageal ascending aorta short axis T view. Image A on left upper showing two-dimensional image showing narrowing of the right pulmonary artery anastomosis. The diameter is 0.7 centimeter. B showing the colored Doppler anastomosis showing turbulent flow across the right pulmonary artery anastomosis. Again C showing the continuous wave Doppler analysis demonstrating a significant pressure gradient across the anastomosis, and peak gradient is 40 millimeter Hg, which is underestimated in the setting of the 2 liter per minute of the CPB flow, and because patient was on CPB, and D image showing on the right lower showing the T guidance of the PA catheter. You can see the tip of the PA catheter and being advanced beyond the anastomosis to obtain the direct measurement of the pressure gradient. Another case of liver and double lung transplantation for cystic fibroma. After successful implantation and right lung allograft reperfusion, PAH and the hypoxemia complicated the implantation of the left lung. Cardiopulmonary bypass was initiated for that to complete the procedure, and upon the left lung reperfusion, again T was done. T assessment revealed that right pulmonary artery anastomotic stricture and acute right ventricular failure, which was refractory to the conventional medical management, and patient returned to the OR next day. Right PA stricture was found to be due to the extrinsic compression by the surrounding tissue and the large hilar lymph nodes. And these were resected to resolve the right pulmonary artery anastomosis obstruction, and the PA pressure and the RV failure settled down. Here again the T and the mid-esophageal 4-chamber view demonstrating RV dilatation. A figure showing the RV dilatation in interventricular septal position towards the left side due to the pressure overload. B image showing the modified mid-esophageal ascending short axis view of the right PA anastomosis with color Doppler imaging. The diameter of the anastomosis D1 is 0.68 centimeter, is less than the 50% of the proximal native ipsilateral PA diameter, that is D2 1.53 centimeter. So turbulence flow is demonstrated across the anastomosis. And figure C showing the T modified mid-esophageal ascending aorta short axis view of the right PA anastomosis with the continuous wave Doppler analysis demonstrating a significant pressure gradient across the anastomosis, peak gradient 24 millimeter Hg only, despite poor continuous wave Doppler signal because alignment was not proper, and there is a persistent antegrade flow across the anastomosis during the diastole. D image showing the T modified mid-esophageal ascending aorta short axis view of the right pulmonary artery anastomosis with the continuous wave Doppler analysis demonstrating an increase in the gradient from prior. Initially we observed is 24, now is a gradient is 50 millimeter Hg. Though image is though the alignment is not very much proper, we have to be the blood flow should be like that, and the color flow we have to align with the Doppler interrogation, then only we get the correct result, but here reasonably okay, and pressure is 50. Another case, patient with the right single lung transplantation done without T in ICU. Patient developed acute allograft pulmonary edema and hypoxia and the hypotension. T performed, which revealed the left ventricle underfilled, significant right pulmonary vein cuff flow reduction, normal pulmonary vein flow in native left lung, and normal biventricular function. Patient returned to the OR, and it was observed that extrinsic compression of the right pulmonary vein cuff by the right pulmonary allograft, which was large, and the edematous allograft recipient thorax size mismatch It was the reason behind this, and a right lower lobe wedge resection was performed when patient was taken in the theater, and right pulmonary vein cuff flow was showing the improved, remarkably flow improve in the T. Here the same thing we can see. The first image of the lung is showing the right lung totally homogeneous and congested. In the B image we can see the pulmonary vein continuous Doppler, and all the waves are diminished. In the C figure, where after correction there is definite improvement in the pulmonary venous flow, and later on D image showing the normal pulmonary venous flow. In a another case, patient with the bilateral lung transplantation, grade 3 primary graft dysfunction and left main pulmonary artery embolus detected on the chest CT. T revealed right ventricular failure, diminished left pulmonary vein cuff blood flow, and the spontaneous echo contrast and thrombosis of the left pulmonary vein cuff. Unfortunately, catheter directed thrombolysis of the left main pulmonary artery thrombus failed to improve the perfusion, and hypoxia of the necrotic left lung allograft and necrotizing necessitating the left pneumonectomy. Here you can see T into 2D imaging from a modified mid-esophageal two-chamber view on A, demonstrating spontaneous echo contrast or smoke along with the thrombus in the left upper pulmonary vein. B showing the T pulse wave Doppler showing imaging from the modified mid-esophageal two-chamber view, demonstrating significantly blunted flow through the left upper pulmonary vein. The time intervals for the S1, S2, D and A waves have been markedly with the horizontal lines, marked with the horizontal line for the comparison of these with the right upper pulmonary vein. As you can see in figure C, there is a normal right upper pulmonary vein, T pulse wave Doppler imaging from the modified mid-esophageal two-chamber view, demonstrating the usual triphagic flow pattern with the slightly elevated velocities, because transplanted lung is not having the much flow. The major flow is on the normal lung, and the normal pattern using the horizontal lines labeling the time interval for S1, S2, D and the A wave, and last D showing the CT angiography demonstrating a large pulmonary embolus in the left main pulmonary artery. In a systemic review to assess pulmonary vein cuff dysfunction, stenosis or thrombus in the lung transplantation, some authors discovered that a pulmonary vein diameter of 0.48 plus or minus 0.2 centimeter and a pulmonary vein velocity of 1.59 plus or minus 0.66 millimeter per second as measured by the T predicted pulmonary vein cuff dysfunction, which has a high mortality rate of the 32%. Unfortunately, threshold value for the pulmonary artery anastomosis dysfunction like stenosis or thrombus are not available, but we can very well see the thrombus or stenosis in the pulmonary artery. Both pulmonary artery and pulmonary vein cuff anastomosis should be assessed with the 2D TE morphologically and with the Doppler echocardiography after reperfusion of the allograft. After closure of the chest wall, these anastomosis should be assessed again because allograft recipient thorax size mismatch would compress the pulmonary vein cuff and causes the graft failure, as we discussed in one case. Other benefits of the T: hemodynamic monitoring and guidance of the fluid resuscitation, hemodynamic perturbation from the clamping of the pulmonary artery to implant the donor lung include the pulmonary hypertension, RV failure and systemic hypotension. Conventional invasive monitoring with the pulmonary artery catheter only provide the numerical measurements but lack of the ability to diagnose the etiology for the failing RV. T provides real-time morphological assessment of the RV in the setting of severe PH, and if at all required, mechanical circulatory support can be instituted rapidly to avoid the cardiovascular collapse. Concerning fluid administration, the donor lung is at high risk for the pulmonary edema from the excessive fluid, because the donor lung lymphatic cannot be anastomosed to the recipient's lymphatic system. As a result, pulmonary interstitial fluid cannot be removed rapidly. So, one must be very much careful about the volume replacement in such type of the patient. At the same time, less volume also will not be tolerated. So, over administration of the fluid can cause the primary graft dysfunction, and based on the inaccuracies associated with the central venous pressure monitoring, T assessment of the ventricular filling is important. So, one can decide, we can use the Vexus score for this also. We have to assess the pulmonary, and we have to assess the IVC filling, we have to assess the portal vein, hepatic vein and renal vein blood flow, and we can access the Vexus score, make out the Vexus score, and accordingly Vexus score we can give the fluid inside type of the patient, whether the patient really require fluid or not. So, conclusion is modified transgastric hepatic vein view and the lower esophageal hepatic vein view, along with the other standard basic views of the diagnosis, and guide real-time surgical management of the orthotopic liver transplant, ultimately leading to the graft preservation and the patient survival. T monitoring helpful during the lung transplantation for hemodynamic monitoring and vascular anastomosis assessment, right ventricular function, tricuspid regurgitation, and find out the reason for the hypoxia, and as a guide for the fluid resuscitation. This is the figure showing the left pulmonary vein. This figure showing the right pulmonary vein. We can see the right upper pulmonary vein and the right lower pulmonary vein in this figure. Unfortunately, I cannot play the video. Left pulmonary vein, to obtain the left pulmonary vein, first develop mid-esophageal four-chamber view, and then withdraw the probe slightly to allow the aortic valve to be visible, and finally turn the probe to the left and retroflex to allow the left side of the pulmonary vein. And for right pulmonary veins, to obtain right pulmonary vein, first develop the mid-esophageal four-chamber view, withdraw the probe slightly to visualize the aortic valve in the center of the screen, and then we have to turn the probe towards the right and retroflex. We can easily see the right pulmonary veins. Thank you.